Hello, everyone. I'm Luis Ortega Paz from PCR Online and Early Intervention, and we are here digitally, not physically, but we are covering the AHA for PCR Online, and we have the absolute pleasure to host Dr. Chris Rajkumar and Dr. Rasha Al-Lamee from the Imperial College of London in London, UK. They are presenting today, Saturday, as a late-breaking clinical trial, the ORBITA-2 trial, which is a continuous of the landmark ORBITA-1 trial that shocked Twitter a couple of years ago. So I'm a really pleasure to host them. Dr. Rasha, she is kind of the family. She's also an editor in our intervention. So I'm very happy to have her with us today. And also Chris, which is has been deeply involved in the planification execution of this study. Welcome, Chris and Rasha.
Thank you so much. Great to be here.
Okay, Chris, please walk us to the history of ORBITA-2, going from from the background, what you did this trial, how you did it, and you can mention us the key messages and the results from this study.
No problem. Well, as your listeners will know, the first ORBITA trial left us with a question. ORBITA-1 told us that in patients who are already on maximally tolerated antianginal medications, the difference between PCI or a placebo was non-significant. There was no significant difference in the primary endpoint of treadmill exercise time. That left us with a question. That was, well, is it just that PCI is not very effective at angina relief? Or is it that the antianginal medication that patients were taking had attenuated its effect? So we designed ORBITA-2 to answer that exact question. So ORBITA-2 was a randomized placebo-controlled trial of PCI for stable angina, but with a few key differences. Firstly, and most importantly, in ORBITA-2, we intentionally diverged from guidelines and we randomized patients to either PCI or a placebo procedure without background antianginal medication, so that we could test the unattenuated efficacy of PCI on angina relief. We also randomized patients with both single and multi-vessel ischemia, and we followed them up for longer, for 12 weeks this time. Finally, the primary endpoint was different. The primary endpoint in ORBITA-2 is an angina symptom score, and this was based primarily on patients' reports of their angina that they gave us every single day using a dedicated smartphone app. The primary result of ORBITA-2 is that we found that PCI significantly improved the angina symptom score, the primary endpoint of the trial, compared to placebo, indicating that patients who'd had revascularization had a better angina health status at 12 weeks of follow-up. Interestingly, we saw that actually from our daily data, we could see that patients, the effect was immediate and it was sustained throughout that 12 weeks of follow-up. And by the end of follow-up, patients who'd been revascularized had about a 3-fold greater likelihood of being freed from angina compared to the placebo group. Just looking at some of our secondary endpoints, we also found that PCI gave you about a 60-second greater large increment in treadmill exercise time compared to the placebo group. So it was a positive trial in favor of PCI.
So this is the moment that we should stand up and clap, no? Or applause. Okay, so PCI beats the placebo effect. I'm very happy. I think all the community is very happy about that. First, congratulations for all your hard work as a team from the Imperial College of London, for all the physiology, for all the all the studies you have done and have enlightened us the topic for the rest of the community. I will do a couple of questions, if you don't mind, to Dr. Rasha. I will ask in detail, because I know that for ORBITA, this is a very important part of the study. It's about how you perform the masking, the blinding of the patients. Very complex, very, I would say, up-to-date study, because you use smartphones, apps, you use this type of masking. So if you can enlighten a little bit about that specific details.
Yeah, thanks very much, Luis. Well, so what ORBITA-1 really taught us was how to perform placebo-controlled trials of interventional procedures. And I think it really started to set a framework and a standard for how we do this. And actually in ORBITA-2, we did very much the same thing. So what was, of course, incredibly important was from the point of randomization, both the patients and their medical and research teams were blinded to their treatment allocation. And in order to do this, what we did was patients came into the cath lab. They had all the same steps for the PCI and the placebo arm. So they had local anesthetic in their radial artery, a needle into the artery, and then catheterization with angiography performed. They also had physiological assessment. And throughout all of this, they were wearing headphones and listening to music. And then once we performed physiological assessment, what we did was give them incremental doses of benzodiazepines and opiates until they were at a deep level of conscious sedation. And once they were asleep, but obviously still ventilating, we then randomized them 1-to-1 to PCI or placebo. Then for the PCI patients, of course, we got on and did the PCI procedure. For the placebo patients, they stayed asleep in the cath lab for at least 15 minutes before they came outside. And importantly, outside, what we did was ensure that there was a standardized handover with no transfer of information as to anything that might tell you what had happened in the lab. So doses of heparin, things that might give the game away, were not transferred to the lab, to the cath lab team, the ward team outside of the cath lab. And then importantly, once that patient woke up, they were not told about treatment allocation and in fact had no further contact with the cath lab team. What also happened was that the patients were discharged home with exactly the same discharge letter, telling the primary care physician that they'd had a procedure, but that we couldn't tell them whether they'd had PCI or placebo, and we would tell them in time. And for 12 weeks, they had no idea what had happened. They had exactly the same dual antiplatelet therapy. And then at 12 weeks, they came for follow-up, in which they were followed up by a blinded research team, had all of their research investigations, and then finally at the end of that visit, were told what they'd had done. So it was quite rigorous. And of course, it was incredibly important for us to separate unblinded members of the team and blinded members of the team and make sure that we never leaked any information to either the patients or their medical or research teams.
I mean, that's great. We know from a research perspective how difficult this if you even want to blind the type of stent, this is just a huge amount of work for doing. So blinding the whole procedure, I mean, it's congratulations, as already we endorsed them in the first ORBITA-1 trial. Going to a next question, to what is next? No, and I think the key question here will be, which are the clinical implications of these findings? Now, when the colleagues, in abroad the world that are watching us, they will have patients in the tables and they have to decide how to proceed. Which will be your recommendations based on the results you got?
Yeah, thanks for that, Luis. So I think the key thing, and the part that we'd really like people to understand, is that we now have 2 evidence-based pathways. And as you know, and I've spoken about for some time, we believe that to test truly if any treatment can work on symptoms, it must be done with placebo control. And the unblinded data gives us an exaggerated effect size. And we saw this even from ORBITA-2. So even though we were very pleased to see that PCI did improve exercise time and symptoms, the results were still a smaller effect size than in unblinded trials. But what we have now is the ability to give patients and their physicians 2 pathways. So you have a patient with stable angina and with severe coronary artery disease and evidence of ischemia, as we showed in ORBITA-2. And what you can offer them is either the pathway like ORBITA-1, which is guideline directed. You give them antianginal therapies up to high doses, as we did in ORBITA-1, and then they will have some symptomatic relief, but any incremental benefit of angioplasty is probably very limited. The second pathway is actually quite different. It's an upfront PCI pathway, where you can offer patients that procedure upfront, knowing that that's where the biggest benefit probably will be. And then you see how they do. Now, interestingly, we know that in both trials, there is a proportion of patients who will remain symptomatic despite our best efforts. And that's going to be very important for us to work out over time. And that's the next step for us. How do we work out which patients will have the most benefit and which patients probably won't have much benefit from either pathway? But I hope what we've got now is 2 placebo-controlled pathways that you can talk to your patients about. And also what's really important is to talk to them about the pros and cons of both approaches, because of course both have their own limitations and both have their own benefits, and sort of work out between physicians and patients what the best approach might be for them as individuals to personalize their care.
But I think it's wonderful, and I think it's something that progressively we have been changing, you know, offering patient meds, especially if they are not into the mood of going into an invasive procedure. So I think that that will be even, you know, with the role that CT scan is gaining in the clinical practice, it can be even, you know, like even a combo, no? You can go for a CT scan, you know, you have disease, they put it on pills, and you're doing well, you're doing well. If not, you can always go for invasive procedures. So I think it's kind of it's a very interesting message, and it will take time for being implemented. Of course, implementation research is not fast, but I think it's very reasonable, and your data support it. I will do a last question. I usually try to do my last question, you know, in some topics that are not extremely related to the study, but and the last two interviews we have done for PCR Online for our intervention, we have interviewed a senior author and junior author, which is not always common, and I applaud that. I remember we published a couple of years ago in our intervention an editorial comment, a perspective editorial comment by a prior mentor of mine, called you know, the staff and the fellow mother/father relationship. So can you speak about that? You know, because what you have achieved is very important. Is you know is very good science, and I know it's a team, and I know there is a senior, there is a junior. How if you can describe your experience for us, I will be very glad about that.
Okay, well, maybe shall I start, Chris, and you can talk about your experience of it. So for me, it's been really important to recognize that to pull off these clinical trials, you rely on so many people. We had 14 centers in the UK. We had a whole bunch of my PhD students. And in fact, the first 5 authors of the paper are all my fellows. And for all of them, it's going to be really important over time for their incredible hard work to be recognized. Chris put, you know, his heart and soul into this trial, and so for me it was really important that he was the first author, and it's not my style to kind of steal these moments away from my fellows. You will hopefully see lots of the other fellows come over time producing the secondary analyses from ORBITA, and I really would like to set a standard for the future, which is about team science. And I think it's no longer the place for just one person to present the results and take all of the glory, but we've got to recognize the many people, including the patients, who are part of our research. But I don't know, Chris, how do you feel it's gone?
So I'm finishing the 4th year of my PhD, and I only plan to do 3 years. So clearly, the relationship was good enough for me to do another year. But no, it's been an incredible journey, an incredible experience with amazing mentoring from Rasha. What I found so valuable is Rasha had so much experience from conducting the first ORBITA trial and gave me so much advice, you know, performing these procedures around the country and going to the different sites and meeting the patients and getting the patient's trust. And I think you can only do that when you've got such fantastic supervision from above, sort of guiding the pathway. And you know, I'm all for a team science approach, and we've got a wonderful team here. There's a couple of other fellows who worked their socks off as well and done a fantastic job.
Okay. I really appreciate your answer. I know it's a kind of a different question, but we're speaking for young people, also for all the community, for interventional PCR Online. Also, I forgot to mention that we published the rational design of ORBITA-2 in our intervention. So we will put all the links for all these articles in the interview. Also, congratulations to all the team. 14 sites, more than 400 patients. I don't know if you had enough space in the supplementary appendix to put all the angles of the...
Oh, we've done it again. Yeah, they're all there.
Okay,
and
great.
And even despite it being multi-vessel disease, so there are many pages of angiograms for you to look at.
Okay. I really appreciate your time. Dr. Al-Lamee and Dr. Rajkumar. I really appreciate this strictly scientific interview, funny between friends. I really appreciate it. I've enjoyed it, and this is for all the community, PCR Online or Intervention watching us. Keep tuned, because we will be in AHA delivering what we think is the most related and most hot topics for interventional cardiology for you to know. Thank you.